Thank you, Ko. Nice talk. Nice pictures. Just colorful. Nice. So we will switch to the Q&A session, and perhaps we'll start with some questions I had via Slido, and we can start a discussion. So perhaps we start with the first talk, Tina's talk about adenomyosis, and Ashraf just asked us what is sensitivity, what is specificity, and I guess Tina, this comes back to what is the gold standard, and especially for adenomyosis, is there a gold standard? Is histology a gold standard? Is histology always a gold standard, depending on who is performing histology? What do you think?
Thank you for this very good question. So to answer the gold standard question, histology, histopathology in a routine care is absolutely no gold standard. That has been shown in many studies. The sections that are taken out of the specimen are usually too few to secure a good diagnosis of adenomyosis through histology. We also see a very huge variation between pathologists. And this is the most important thing. Women that undergo hysterectomy today, with the other means that we have to treat women with different problems, are really just the tip of the iceberg. So we are moving away. I think we who work intensively with adenomyosis, we don't consider histopathology as the gold standard, but an expert ultrasound using 2 and 3D, I would say. And most researchers on this would agree. So the first question was, what was the sensitivity and specificity for the cutoff?
Well, I guess it's more, if you look at the literature, you look sensitivity, specificity figures, but what are we talking about? I think that's what I mean. If you look at different papers, are we talking about the same? We just now after your talk that when we talk about junctional zone thickness, we are not talking about the same thing if you're over all the papers. But if you look at sensitivity and specificity figures, what are we talking about?
I think for junctional zone measurements, and I hope my talk made that kind of clear, we don't really know, because we only have studies that are really user dependent. And I think, and that's the end of my journey for now. I'm continuing on this journey, but I think measuring does not add any value. And I also looked at it in my study, in the material that I had, what did actually, even if there was some statistical connection, what did the measurement actually add? And it added nothing. It added no value. It didn't help. It created a lot of false positives, false negative, especially in MRI, which was quite mind-blowing also for our radiologists. So don't measure the junctional zone. You have to look at so many diagnostic signs. You have to look at all the 2D signs first, and then you go in 3D and look at them. And I think the new Musa paper with the direct signs and indirect signs is a new fresh start to maybe have better guidance on what signs are more important to look at. And those are primarily the direct signs where we really see adenomyosis. And this is wonderfully done with 3D, as a meta-analysis has shown. I hope
it's very clear message, and important message. But perhaps staying on adenomyosis, there was a question from Alexandra, as perhaps a question for Deborah, and she asked, how can you differentiate sarcoma from adenomyosis?
That's usually not very hard because adenomyosis tends to have typical features. And adenomyosis doesn't normally cause significant disruption to basic uterine morphology. In some cases, it will distort the cavity, but you can always see endometrium. Outer uterine contour is smooth, although occasionally adenomyosis will invade towards bladder and in the pouch of Douglas, which can cause sometimes concerns. But generally, sarcoma look dramatically different. The organizational vascularity is different. The appearance is different. And with some experience, I don't think that that in most cases you're going to have great difficulty saying separating one from the other.
Okay, that's clear. Another question about if you have a pedunculated sarcoma being figure 1 or figure 7, is that a guarantee that it's not a sarcoma or totally not?
It's excellent questions, and all my false negatives came from pedunculated sarcomas, because common wisdom is that, and from Antonia's papers and my studies, is that a sarcoma is an aggressive invasive lesion which will disrupt uterine morphology, and it will be very obvious. But there are some cases where sarcoma it resembles pedunculated fibroid. It often is relatively large, it can have multicystic appearance, but the surface is smooth and there is no obvious invasion. And these are the cases when you're going to have difficulties, and this is when I usually failed to diagnose it. The other problem which I couldn't address in 10 minutes are atypical fibroids, smooth uterine tumor of uncertain malignant potential, fibroid with a high level of mitosis, which is still benign. So there's a group of tumors in uterus which are as irritating as borderline tumors in the ovaries, that they have features of both malignant and benign lesions. And sometimes even pathologists are struggling to say which one is which. So it's a complex issue, but generally, majority of sarcoma luckily will look relatively typical, have features which are discussed, but you have to be prepared that some of them you're going to miss. That's unfortunately nature of our gynecological scanning, which is an endless challenge for the rest of our careers.
Indeed. And another thing, I mean, we have size matters, and I mean, if you have a huge fibroid mass, but well, we all know some people, and it's genetic, and have extremely big fibroids, myomatous uteri. Again, then we say, okay, there are a lot of fibroids that will be benign. Is it always the case, or can you have a sarcoma just hidden between all other big fibroids?
You can, and the particular problem I faced are sarcomas which come after previous mammectomy, and in my experience, for some reason, previous mammectomy actually increases chance of sarcoma, although histology from first operation is always benign. Recurrence of fibroid can be sarcoma, and that's something which is very hard to avoid misdiagnosing. But nevertheless, very fast growth, unsettled features, and again, deposits in the pouch of Douglas or vesicular pouch are quite important. You have solid deposits in a women with unsettled fibroid. But the other thing which I think is worth mentioning is we do quite liberally, if there's diagnostic uncertainty, we do biopsies. We do it quite a lot now. I must say, mainly to calm oncologists down and say, this is not sarcoma, this is fibroid. And that works very well. Our pathologists are quite nervous about that, but using a large TrueCut biopsy needle, we have got actually excellent correlation with final histology. So that's something I would consider, because sarcoma is a devastating diagnosis. Although they say survival rates are great, all women I've seen have died, and they died terrible death. And I think if you're not sure, rather than taking chances, I think it's reasonable to biopsy. As I said, we do quite a lot. I hope that this will become more prevalent in future practice.
That's interesting. Perhaps we move to the elastography now from sarcomas and Kobe. I know you're only starting your research on elastography, and you don't have a lot of sarcoma cases, but do you expect, I mean, what are the limitations of elastography? If you have a huge mass, will you have a clear view using elastography? Sorry for the hard question.
No, that remains a problem. You cannot look with the shear wave numbers are mentioned around 3-4 centimeters. There aren't really numbers mentioned with the strain, but if you put a pressure on a lesion, the deeper you go, it's harder to get the compression and the deformation. So depth is a main issue. With very mobile uteri as well, when you use the strain, it might be become handy to put some pressure on the abdomen so you can use the pressure. Otherwise, with the very mobile you try, they just move away instead of having some compression when you use the strain or the stress on the tissue.
I think for oncology, I think Elizabeth, you used elastography in cervix cancer.
Yes, we did. We did a study using strain elastography, and we found that elastography could be used to delineate the tumor. And we also found that more advanced tumor had another strain rate than a less advanced tumor. But I do agree that we need to do more research on this subject. But there seems to be something that you can use on top of grayscale imaging, just like we use Doppler on top of grayscale imaging. So I think that we need to work more with elastography to know its true potential.
Yes, thank you. I think go perhaps a small question about the. You think the measurement is hard? I mean, it's hard. I mean, not in in elastographic terms, but it's difficult to obtain reliable, reproducible measurements using elastography.
Yeah, it is hard with both techniques actually, because with the strain you just get a color map, and that gives you an ID, but you don't have a real number that you can put on it how hard or soft something is, and that's why they introduced the strain ratio. But that poses the problem that you need to select two regions of interest to compare, one in the lesion and one as a reference, and there you get bias as such because you need to select them yourself, and in very heterogeneous lesions it's very difficult. And with the shear wave, it's the problem. You have multiple articles, even in a normal uterus you get different values, and those are absolute numbers, and they say it's because of different machines used, different operator. So even there where you have the absolute numbers in the shear wave technique, they propose to use the strain ratio as well. So to get an absolute number, it's difficult to reproduce. And you can assess the color map. One of the authors just put a score on the color map to try to objectify, but once again, putting a score to the assessment of a color map is easy for bias and subjective as well.
So in a couple of years, when you have finished your research, just as Tina, you will say, "Look, don't measure," and then you will have hard data to substantiate that. That's good. Perhaps back to Tina then, because we Tina, about adenomyose and we talked about the junctional zone, okay, but there is also adenomyosis, external adenomyosis, just subserosal adenomyosis, and you have also cystic, big cyst adenomyosis, and then you have the adenomyosis disturbing the junctional zone. Is this the same entity, or are these different diseases?
Thank you for that question, Terry. And you know that I can't answer that if I could.
Try.
Yes. I think it is different diseases. We see in studies that try to correlate this to clinical profiles that the women have a bit of different clinical profiles, especially the adenomyosis that leaves the junctional zone intact and is only in the outer part. Bourdon and Chaperon just recently published a study correlating it to deep infiltrating endometriosis. So this might be a subtype of endometriosis, but however, it also occurs without endometriosis. But the looks and the clinics is different. So I think we're dealing with subtypes of adenomyosis which require more research. That's always the boring answer to that. And we first need a better classification and same language. Everyone needs to call their adenomyosis the same. We can't go around everyone making up their own definition of focal and non-focal and diffuse and so on. So I think FIGO is working on this, and also MUSA is constantly working, and you have updated this in 2019. But I think it's really important to stick to the same terms in order to figure and find out of this in the future. But this also, I hope my answer is not too long, but I think it has also to be accompanied by molecular investigations. Only imaging will not give us the answer. We really have to find out what is going on in the molecular processes and also correlate this to molecular patterns.
Yeah, nice question. I mean, there's room for research, luckily for the youth. But about age, just about age. Also, they appear you have adenomyosis in young women. Sometimes I think perhaps more cystic one, and then you have adenomyosis in porous women after cesarean section. So does that tell something about the pathogenesis, or what do you think?
I think we know we have this tissue injury and repair theory where we think that constant strain on the junctional zone allows endometrium to invade into the wall. And this is obviously maybe also physiological weakness of the uterus that we see mostly in Paris women, while we see adenomyosis away from this invasion and strain more in younger women. When you mention cystic adenomyosis, I just want to mention another thing to confuse our listeners a bit more. There is a thing called ACUM, accessory cavitated uterine masses, that are often called the same thing like cystic adenomyosis, but this is really another entity that we're just learning more about. My colleague Joel Naftalin is doing a lot of research, has published a paper, very nice paper on it, and with Professor Jurkovic. So I think this is not actually adenomyosis, this is a different entity, and we have to know that.
Exactly. That's also very interesting stuff. Perhaps for Deborah, there are questions from the audience about how can you make difference between necrosis and just cysts in a fibroid. Is there, because what are the features to rely on to differentiate between an atypical and a atypical fibroid and the sarcoma?
What I was trying to illustrate in a couple of slides, that look at the degeneration and necrosis of fibroid. It's usually identified by relatively large cystic areas with relatively clearly defined border within the fibroid itself. And the surrounding structure of the lesion is often preserved. What we're talking about necrosis in sarcoma, we are not looking at the cystic area, we look at the solid part of the tumor. The solid part of the tumor looks unusual. What will resonate with you there is, if you look at a cancerous polyp in the uterus, it has this gray solid appearance, which is very different from benign polyps. Similar feature you will observe in sarcoma. It's something, as I say, I've seen probably about 500,000 fibroids in my life, so it's relatively easy for me to see something which is rather odd. But this is feature which is seen in many sarcomas. It's not entirely specific, something can mislead you, but it's very striking. When you press on tumor, it's relatively soft, and I use this term cooked meat, which is not very very pleasant. But anyway, that's exactly what it reminds you of. It's a tissue which has been destroyed, not because it has lost completely vascular supply, because it's growing so fast that it just degenerates as it goes along. It's something which probably would best illustrate with maybe 100 slides, looking at the fibroids, looking at sarcoma, then you can actually get the feeling. But in pattern recognition, it's always quite hard to articulate exactly what you're seeing. It's based on what on your experience, your memory, and assessment of patient at the time. But it's a feature which I always find very useful. And I look for this first when I'm faced with a large fibroid, which some people may think could be cancerous. But if we have time in some other lessons, I can show more examples which I couldn't today within 10 minutes.
Yeah. So the message is a little bit as Steve Goldstein said in the 90s. Look at a donut, not at a hole. Now you say don't look at the cyst, look at the surrounding, at the tissue, and that the tissue is the issue, and that's a very interesting. So I think we slightly go to the end of this Q&A session. It was very, very interesting. We have more questions to go, but perhaps we can leave it for the the last part of the Q&A, we have time, but it was anyway. There are also some questions about elastography and ovarian masses and so on. So go after the last session. Perhaps you can say some words about that. But now we first of all, Tina wanted to show a slide, and then we have a short break for the sponsor. So perhaps Tina, you have to.
Yes, thank you.
Floor.
So now you have to be quick and get your phones out to scan this QRS code or take a screenshot. This is a study for all of you who see and treat women who have adenomyosis. And now you can participate in a global consensus study on what is important in adenomyosis research. And this project is called COSAR. You can read more on our webpage, but if you want to participate, you need to be really quick, because this survey, it closes tonight at midnight UK time. And so this now is the last chance to contribute with your opinion. Thank you.
Okay, thanks, Tina. And now we'll look at a short video from our sponsor.